can't see, my screen is not showing. Is it showing? I don't see it.
We see you, but you are...
Yeah, you can let them in.
Okay, I'm just going live on YouTube and then I'm letting people in.
Okay, I can see myself now. Yeah, sure. Yeah, just at shoulder stage, so I'm not wearing my arms thing today, so but I'm trying to balance my hand on the chair. Not to shock people with looking at me and see my. Let me just, yeah, we can let people in. Somebody's even calling me now. Let me just check. I'll switch off my video and mute myself, Shabir, and then we'll, as soon as we're done with everyone, we'll see how many people are in. Then we can do the introductions, and then Kambo will let you play the video. Okay, good evening, colleagues. We welcome once more. We are seeing a few people are getting in, so as soon as those in the waiting room have been admitted, we'll start with our webinar. And sorry for letting you in quite a bit late tonight. Can you let me know if we can start?
Yes,
There's still quite a number of people in the waiting room, I see.
We can start, Dr. Vila.
Have you got all of them in? Because I see there were a few people in the waiting room.
Yes, everyone is in.
Okay, thank you very much. Thank you very much, colleagues, and welcome once more to our weekly webinar hosted by Phoenix Health Group. And we've had a good time with you joining us every week since 2020, and we are glad that you are able to continue with these webinars on a weekly basis. And we are quite fortunate also that we are able to source different speakers from different fields within the health sector who are able to join us and give us their knowledge, experiences, and also latest information on the research that they are doing. And this is one of the evenings also that we're getting latest information on therapeutics that are being used in mental health. As usual, these webinars are CPD accredited, and so we request that you, well, we hope that you, when you registered, you provided us with your full details about yourself, your registration number, and the regulatory body that you're registered with, so that we can submit that information, upload it, and give it to the relevant parties, so we'll then be able to send it to the HPCSA or nursing, or for the Nursing Council and Pharmacy Council and other professionals. You get CPD certificates, you get attendance register, certificates of attendance, and then you can submit them to the relevant regulator. And secondly is that we request that you do not necessarily have to put in your information on the chat box about your name, surname, and MP number, whatever is relevant, because that information, when it is provided as you register, it will be sent to the relevant parties as I've indicated. But also request that you mute yourselves and you also switch off your videos so that we make sure that you get a good feeding from the internet connection or your Wi-Fi connection. And so this evening, we're quite excited to have Professor Shabir Moosa, who is a family physician with an MBA and a PhD. He works in public health service clinics in Soweto primarily, and is also attached to the University of Witwatersrand, where he's an associate professor in family medicine. He has an extensive experience in rural general practice and the development of family medicine and primary care services in both the rural and the urban district health services in our country, and also in association with the rest of Africa. Professor Moosa is involved in development and research around family medicine, community-oriented primary health care, and health management for universal health coverage, and is also a member at large in the executive committee of WONCA, World Organization of Family Doctors, and an executive coordinator of PHC, the African Forum for Primary Health Care, bringing African PHC team leaders together to advocate for PHC. He has a qualification met from Medusa, and also an MBA from Wits and a PhD from Ghent University in Belgium. And so this evening, Professor Shabir Moosa will be talking to us about mental health and new evidence on therapy. I know some people are saying, because he's a family physician, all about association with psychiatry, but I think he will share his insights and thoughts and latest research information of this. So we're quite excited to welcome you, Professor Moosa, and I'll hand over to Kamu to continue and interact with Professor Moosa for the presentation. And thank you, colleagues, and welcome once more.
Thank you. Well, thank you all very much for joining us, and thank you to Dr. Bila and the clinics group for inviting me. Unfortunately, it's a really bad time, so I had to prepare in advance by getting a video that of my talk. I'll hopefully join you at the end of it and continue from there. I must say before I leave you and you'll see the video, ketamine is what I'm going to talk about, but it's not the only solution. It's an addition to the current management range within mental health. So let me show the video. Thank you very much, and I'll see you shortly.
Hi, my name is Shabir Moosa. I'm going to talk to you about mental health.
Hi, Prof. The video is not playing. Hello, Prof. Are you there? Hello, Prof. The video is not playing. Can you please restart it again?
Hi, Kamu, can you unmute, Prof?
Yeah, I'm struggling to
Let me start sharing the
this
video. Give me a second.
years. It certainly has been dramatic when I look at the studies I share in the last few years. So just to give you some background that
Sorry, I'm going to just quickly check the settings. It should have allowed to share. Hi, my name is Shabir Moosa. I'm going to talk to you about mental health. Is that okay?
Yes, it seems to be fine. Thanks, Prof.
The potential use of ketamine. Firstly, I want to share a conflict of interest. I'm medical director of ASA Health. I think there might be critics out there who say that this off-label use of ketamine is dubious. But I think that we also need to understand the conflict of interest where drugs that are manufactured get so much more in the way of resources that can show its benefit. This drug does not that same benefit. So I hope one gives it fair thinking. I also want to say that I've had personal experience with ketamine, and that has made me a strong believer. My experience has been that I've had depression, anxiety, and in fact that presented itself as fatigue and then dizziness for quite a few years before I realized, after much investigation, that it was actually depression and stress. And then I had been on antidepressants for a while and realized that going from one to the other is not producing anything. I'm on Cipralex double dosed at maximum, and that was for a couple of months until I tried ketamine, and voila, 24 hours, there was a big major difference. So that personal experience is mine to share. I also think that when we're looking at it, we need to have the best in evidence, and I'm going to share with you what is there in the way of systematic reviews and meta-analyses. And I think one needs to be aware that there's a lot of evidence out there that hasn't been put together strongly enough, that need better collection and better doing. So I hope that one is going to get this improved dramatically over the next few years. It certainly has been dramatic when you look at the studies I share in the last few years. So just to give you some background, that Craig found in 2022 in a national survey in South Africa, that mental health is a big problem. We've known that for many years, but I think it's very notable that almost 25% or more than 25% of people in South Africa have clinical depression based on the PHQ-9. They also have quite high levels of anxiety using the GAD, Generalized Anxiety Disorder Questionnaire 7. This compares very poorly to other countries like in the US at 6.9%, or the most recent one in Brazil at 7.9%. And we're almost 2 or 3 times worse than those countries. What has been found in South Africa that those people most at risk are actually those who are retired, those over 65 years, widowed, divorced, separated, and living in metropolitan areas, and those with only primary school education. I'm going to go through a background. We all know that usual therapy, and I'm not going to go through it, although medication is a mainstay today with the SSRIs as being the most recent kid on the block. There have been newer treatments like the serotonin norepinephrine receptor inhibitors, and then new atypical antidepressants that have come on the market, some of them quite old, and antipsychotics, where psychiatrists are considering the use of it in depression, with 25% of depressives having psychotic features. Psychotherapy is in fact a mainstay as well. Some of the newer therapies, and I'm not going to talk about it today, but it's cognitive and dialectical behavior therapy, very useful, atypical for psychologists, but a very useful way of dealing with patients with emotional challenges. Then I'm going to talk very extensively about ketamine therapy and see how what the evidence suggests about it. Ketamine was discovered in 1965, and it was approved for clinical use in 1970. It's a safe intravenous anesthetic. It interacts with a number of receptors in the brain. It has, unfortunately, the unpleasant side effect of dissociation, which many patients who go through anesthetic don't particularly enjoy. It's still it's declined in use with newer anesthetics like propofol, but it's still considered a WHO essential medicine for both developed and developing countries. The ketamine has garnered new interest in the last few years, probably more so in the last decade, but it's been since 2000. And it's potentially in alternative clinical settings such as depression, especially in suicide. And I think this is the real big focus with lots of studies to show benefit, but also somewhat in bipolar disorder, in anxiety disorder, particularly social anxiety disorder, PTSD, substance abuse or substance use disorders. It's also been shown. It's long been used for chronic pain, with a lot more work being done around that and other conditions which have a neurological element, and one notably as COVID, long COVID, which is considered worthy treating with this, and a few case studies that show its benefit. As opposed to the various SSRIs and other monoaminergic drugs, this ketamine works within hours rather than weeks. It also lasts after the infusions, whether single or multiple, usually 6 over 2 weeks, 2 to 3 weeks. It can last up to a month, but the long-term effects are not yet fully understood. And these are the studies that have provided some very useful background. The mechanisms of action is still something that's not entirely clear. There is certainly an increased circulation in the limbic system. It's certainly lends itself to the immediate dissociative effect, the thing that appeals to those who abuse it, but that is also important in the process as a measure of the impact on depression. But the monoaminergic systems are those that are affected by serotonin, norepinephrine, and dopamine, and these take several weeks of daily administration to take effect. Whereas in the glutamatergic systems, and that's ketamine, having an effect on it through the N-methyl D-aspartate receptor antagonist, receptors being an antagonist of it, leads to a glutamate surge in the synapses. And this lends itself to postsynaptic signaling that then gets a protein cascade, especially brain-derived neurotrophic factor, or BDNF, and this increases, quite importantly, the synaptic plasticity and dendritic spines. So in other words, it helps your brain to actually shift and reconnect in some way. So it's quite easily seen as a brain reset. It also affects the other two major neurotransmitter systems in the brain, the opioid and the cholinergic systems, but less so. Depression is certainly the one where most of the justification is there. They started off with the seminal study by Burnham in 2000. There's been a systematic review meta-analysis in 2015 by Lee and company, and it basically came out looking at the ketamine as a novel treatment, looking at studies from 1999 to 2013, and found 5 RCTs in the meta-analysis. Of course, I'm going to mention this, that PRISMA guidelines for systematic reviews are not evident in here, but it looked at the depression, Montgomery-Åsberg Depression Rating Scale, or the MADRS, or the Hamilton Depression Rating Scale, HDRS. Ketamine significantly reduced depressive symptoms, and the overall effect at day 1 was very large and statistically significant, but it was sustained at 7 days post-infusion. And I think it was reasonable in terms of quality. A subsequent systematic review, meta-analysis in 2022, looked at ketamine for the treatment of mental health and substance use disorders. It's a narrative synthesis of 83 reports, but included 33 systematic reviews and 29 randomized controlled trials and a number of others that were not in this bracket. It did apply PRISMA 2020 guidelines, and it found that there was strong evidence for the robust, rapid, and transient antidepressant and anti-suicidal effects of ketamine. The evidence for other indications that are mentioned show that they are positive, but not as robust in terms of the evidence so far. So there's clearly more research required, but the research, I think, in terms of depression, is to look at the optimal doses, the modes of administration, and the most effective forms of adjunctive psychotherapeutic support, because it's seen as much more helpful in combination. Certainly, the long-term effects with long-term therapy is also something worthy of looking at. And this study was done by Walsh in 2022. There was a second systematic review and meta-analysis 2022 by Mark and Tony, which looked at the efficacy of IV ketamine for treatment-resistant depression. Key indication for it, again, looked at multiple databases, 28 studies. This was focused on clinician-rated outcome measures, and it looked, again, it used the PRISMA guidelines as well as the Joanna-Briggs inventory to manage the quality. And they found that a single ketamine infusion had a strong effect for 4 hours, maximum effect at 24 hours, but the effectiveness of the ketamine was still present at 7 days post-infusions, with the multiple infusions actually enhancing and prolonging the effect. Although in this study they did not look at the measures after 7 days. Clearly there's a need to look at the long-term safety and efficacy, and I think that's really a key piece of work that needs to be done. Suicide is, again, the second clear indication for it. There was a systematic review in 2018. Single dose of IV ketamine reduced suicidal ideation for up to a week. It, in fact, was not entirely dependent, it was independent, partially independent of its effect on mood. A second systematic review in 2021 by Hochschild found 11 RCTs, and again found that there was a good advantage of ketamine over the control in rapid reduction of suicidal ideation. And the IV ketamine, racemic ketamine, is in fact the most effective. A meta-analysis in 2021 found both associated with reductions in suicidal ideation 2, 4, and 24-hour post-intervention. So it's certainly something useful in the instance of use of suicide. There is obviously a comparison with ECT, and a systematic review was done in 2020, looking at it compared to ECT. There was no superiority of ketamine over ECT for the severity of symptoms and response to the therapy, but the side effects were significantly different, especially the risk of muscle pain with ketamine. Anxiety is probably a less of an indication, but there's some interesting studies that suggest its usefulness in certain conditions. A systematic review in 2021 by Whitaker looked at the effectiveness of ketamine in treating refractory anxiety spectrum disorders. There were 6 RCTs, some in social anxiety disorder, and then PTSD, and then OCD as well. It's a qualitative synthesis with some quantitative analysis as well. Clearly, the acute ketamine seemed to be broadly effective against anxiety, with a key dose-response profile observed for ketamine in terms of changes in the social anxiety disorder. So the higher the dose, the more the social anxiety seemed to be improved. And this seemed to be prolonged with maintenance treatment in the work done. Another study, a systematic review in 2021, looked at it again, and this produced 8 studies looking at RCTs and some few cases. Often there were small samples, but many a times in these RCTs there were quite big effect sizes, so the sampling itself was not material for the fact that there was quite big effect changes. The anxiety symptoms did return to baseline in these cases in this systematic review after 2 weeks. Again, the dissociative effects and mechanisms, basically the psychoactive properties of ketamine may also be contributing in itself, but clearly the drug itself lasts only 4 hours in the body. So this is clearly a change to the physiology of patients. PTSD has been found to be probably a more useful besides social anxiety disorder, and its usefulness has been found there with an RCT in 2021 looking at repeated ketamine administration for chronic PTSD, and this found a significant improvement in these scales versus midazolam, which is the standard control in ketamine studies, where more than 3 times an effect was achieved in the ketamine group. It's of course the duration that it lasted was in fact around a month after 2 weeks of infusions, and usually in the long-term management of it, it's not a repeat of 2 weeks, but a single maintenance dose that tends to keep the effect happening based on multiple case studies that have been published. This review, there was another review by in 2023, which showed the potential use as well, looking at a number of case studies and to randomized control trials, and found that it is encouraging, but there are clearly methodological problems in the research on ketamine. And I'll share some of the difficulties in the research later. Obsessive compulsive disorder is not a very, not much studied, but it has a ketamine systematic review in 2022 based its premise on the fact that the pathophysiology of OCD tends to be glutamatergic in terms of its neurotransmission and effect. But 9 articles, based on PRISMA guidelines, found that they, only using the single session IV ketamine, that there was limited evidence for ketamine and psychotherapy. But clearly there's room for study. Substance use disorder is another very interesting use for ketamine. A systematic review in 2018 looking at the efficacy of ketamine in treating substance use disorders. These included alcohol, cocaine, and opioid use disorders. There were 7 studies, not all of them were RCTs. The cocaine studies showed improvements in craving, motivation, and cocaine use, but the study obviously limited by small sample sizes, homogeneous populations, and a very short follow-up. There was also improvement in alcohol and opioid abstinence rates with significant group effects for up to 2 years following a single infusion. That was one of the studies, but this was not placebo-controlled. The potential is there for ketamine to facilitate abstinence across a number of substances of abuse, and it warrants further investigation. There was also an overview of 6 ongoing studies of ketamine in the treatment of alcohol, cocaine, cannabis, and opioid use. So clearly it's ballooning in terms of how ketamine might be able to assist in this space. Another review in 2021 by Martinotti found the therapeutic potential for the ketamine in the substance use disorders, and it found that motivational enhancement therapy together with ketamine had produced significant reductions in alcohol consumption in those prone to alcohol use. IV ketamine certainly significantly reduced the cocaine use, relapse rate in cravings, and it in fact had a greater and longer lasting reduction in heroin cravings with higher doses of ketamine suggesting a dose dependence. A second review, systematic review in 2022, found ketamine for treatment of substance use disorders being positive but having short-lived effects. So clearly some work needs to be done. A single pilot trial in 2020 looking again at ketamine and motivational enhancement therapy found that this was improved the measures of drinking and alcohols with alcohol dependence. A second RCT looked at 3 infusion ketamines with relapse-based phycotherapy, and this was significantly improving the number of days by 10% that they were abstinent from alcohol. And this clearly is best in terms of trying to do group work, group therapy, or psychotherapy together with ketamine. Other conditions have also been shown to be very important, and I think one that I mentioned earlier is chronic pain. There was a systematic review of a meta-analysis 2018 looking at the efficacy of ketamine infusion in treating CRPS, which is complex regional pain syndrome, and has been found to be clinically effective in short term, but for less than 3 months. There was a Delphi study done in 2021 with experts on ketamine in chronic pain who showed that, or who felt that neuropathic pain was a first indication for ketamine and should be used for that purpose, but they found increasingly the use for usefulness for fibromyalgia, so CRPS, central neuropathic pain, peripheral neuropathic pain, nociceptive pain, sensitization, opioid withdrawal, palliative care, etc. The preferred approach is an IV 4-hour infusion repeated over 4 days with a quarterly top-up, and this obviously combined with non-pharmacological treatment. There was found to be very adverse events with such a long use of ketamine, and it certainly is there's certainly a lot of case studies that are emerging showing its value in long COVID, especially with the neuropsychiatric problems that are there with it. The experience that the patient goes through with a low dose, and this is far lower than is used in the anesthetic as an anesthetic. Essentially, it induces time and space distortions. It can produce hallucinations, but really it does produce strong dissociation. And in fact, that's an indicator of its effect on the as an antidepressant. And essentially, it leads to a person having to dissolve themselves or lead to ego dissolution. And that's found, this dissociative effect is found to be particularly important as opposed to the derealization that occurs with the dissociative effect that comes with ketamine. Obviously, there are challenges in using ketamine. It does produce nausea. Often it's given with an antiemetic. It can produce a headache an hour or so later. There are certainly risks, and this is why it should be given in a monitored environment with vital monitoring through that process. It has basically the biggest problem is that it leads to more hypertension, and this is the kind of effect at maximum at 30 minutes being a relatively small impact on systolic and diastolic pressures in terms of blood pressure increase over a number of infusions. Its addiction is not necessarily true. It certainly is an addictive drug, but probably more than its physical organic addiction. It's a psychological addiction, but there's no evidence for the clinical administration in low doses as is used in this infusion actually inducing any addiction. But clearly it needs to be a controlled substance and used with clinical discretion. In addiction, in places where it is abused, like in Singapore, they have found that it does produce a cystitis. There are other risks, but they're really marginal. These are the major challenges. I think it's really important that we appreciate that as a drug, research for it is challenging. There are other dissociative drugs, but they're all illegal at the moment. It is only the one that at the moment is allowed for off-label use. It is challenging to blind because a patient who experiences this can share that and easily unblind controls if they interact with them or with the caregiver. So it does present challenges in terms of creating an appropriate control for RCTs. So there might be this expectancy that drives the difference in outcomes. Nonetheless, I think the search is on to look at options beside midazolam to be able to look at something that could serve as a placebo without the effect of on neurotransmitters. This space is regulated. The South African Society of Psychiatrists have actually approved its use for treatment-resistant depression, and that's the clear indication in the outpatient setting. It also has some very useful spaces for inpatient setting with suicide, and I think that these are the sort of uses for which it should be considered primarily, and others, on a research basis. It is also regulated both in the US, Canada, with growing number of guidelines that are produced to guide its use as well as guide its the facilities and providers that are implementing this therapy. So KEPSA is the Society of Ketamine Practitioners in South Africa, and I am on the executive board of it, and that is the idea to try and build a consensus group of practitioners who can set the bar for both the certification and the practice of this. The access is certainly something that we need to manage. Obviously, there is a referral network that we are actively seeking out. It's open to self-referral, but we, in fact, will be looking at doing that in collaboration with our network of psychologists, psychiatrists, and other healthcare providers who can work with us on a multidisciplinary team approach with this patient. We also want to try and work with our network on research, looking at particularly the long-term impact, as well as a common element of depression, common type of depression, those with psychotic symptoms, and something that's really interesting in terms of going forward. So thank you very much. I hope this has been useful for you to understand the space of ketamine therapy. You can certainly communicate with me at Prof. Moosa at azahealth.co.za and visit the website of Aza Health at azahealth.coza. Feel free to Google and search out. There's all this research that I've referenced is there at the website on the professional web page, and this presentation as well as the slides will be available at that website. Thank you very much for hearing me, and I hope you will refer to us. Thank you. Bye.
Wow, thank you very much for this refreshing thoughts and research that you are doing on mental health and new therapies. You know, when you propose this topic, I was just thinking about what are the new areas that you want to propose. And I'm sure in the thoughts of many people, you know, they say this is a field for psychiatrists, and what would be a family physician be doing this? But I think you've just opened up our minds and thoughts about this matter. What is exciting or maybe of interest is that you say you started this as a patient yourself, and maybe just have thoughts about the psychiatrist or whoever the physician or specialist who were they looking at the new modalities of managing, or they had an experience in treating patients with ketamine?
Well, I think that the challenge is it's a field that I think has taken a long time coming. There's been some work done in the UCT in Cape Town around it, and it was found not effective. But I think and that's been influencing a lot of the South African thinking, and I think a lot of psychiatrists kind of see that it's whimsical, or saw that it's whimsical. But I think if you're looking at the studies I've quoted, there seem to be a flurry of them that have actually occurred literally in the last 3 or 4 years, where we've got a gathering of the evidence to suggest that, you know, indeed there is some value in what is going on. And especially for the, you know, depression and anxiety, depression and suicide. And I think that's where, you know, that's a large number of patients. It doesn't preclude that, listen, a patient ought to be treated with the current normal, you know, usual modalities, which is psychotherapy and if needed, with pharmacotherapy. But I think that when patients don't get better, and I think that in that space, you might be dealing with a bipolar patient, bipolar disorder. But I think that many a time, I think that there are patients with psychotic symptoms that are very low grade. They don't represent, you know, overt schizophrenic psychosis, but they seem to be dysfunctional and they can be mislabeled. I think that's an interesting space for me, and I'd be very keen to look at that. But the question is, yes, it's a very useful approach. And gathering steam, I mean, just to chat with a young registrar in psychiatry, it's a hot topic in the circles. The difficulty, of course, is the access in the public service. And I've actually tried to do that in Shawelo in Soweto in my day job. This is my evening job. But in my day job, I tried to do it, but it's surprising that there is limited access to ketamine in the public service. Surprisingly, is a ketamine shortage in the country. It's not so easy to get. So that's one of the challenges we have to face.
Okay, quite interesting. And you mentioned SOKEPSA, the Society of Ketamine Practitioners South Africa. Who are eligible members there?
Well, it's SOKEPSA been formed by Dr. Alan Howard, who's got a chain of clinics dealing with ketamine called Ketamines. And he's formed it with other colleagues, but these are psychiatrists, anesthetists. He's an emergency physician. I'm a family physician. So it's an array of people who have interest in that space and essentially would be sort of partners in the management of patients needing ketamine. So at the moment, that's the link. I think it's really very new. There have been, it's kind of, the website isn't functional, and we're busy trying to get that up and running, and also trying to get people to be members in a more formal way than an informal way that it has been working so far. So I think these are some of the tasks for that. I think I've been tasked to try and engage with the public service to make ketamine much more available in the public service. But I mean, all of this requires that the fraternity of psychiatrists, general practitioners need to be comfortable with something that their patients might be quite uncomfortable with. Because remember, it is ultimately a dissociative experience. So it is going on a trip, but it's not for the purposes of that. It's the outcomes that is quite important. So people feel intimidated. They hear of ketamine as a party drug, and they have a number of questions of that. I'm sure that's the kind of challenge all of you would have had, saying, my gosh, anesthetic and now using that, or party drug and now using it for this. It's disturbing. But psychedelics itself is a growing field where, yes, a lot of people are saying, these are sort of batty psychiatrists that are dealing with it. And I myself, a little over a year ago, had much the same view. It sounds very batty, but I think it is important that we tend to look at it more seriously. And I think, I've dug into I've looked around myself at the information in such clinics, and it is not compelling enough. And I said, well, let me go looking myself properly over this period, having used it myself. And yes, the evidence is there enough to convince me that there's worth in it. I do think it's promising enough in a lot of anecdotal work, but that we should do more work. There shouldn't be gaps. I mean, if it's not going to be useful in the longer term, we should know that.
Okay, quite interesting. Yeah, we have quite a number of diverse membership of or participants on those webinars. And we've got a few colleagues who are psychiatrists themselves, and I saw one or two anesthetists logging in. Also, we've got nurse practitioners, we've got psychologists here, and I'd love to hear from them. Yeah,
I'm a little afraid, but anyway, I'm a family physician. I got to take it to my gym.
We've got quite a number of GPs also who are logged in, and I think other specialists from various disciplines. I would love to hear from colleagues who are logged in here. What are your experiences, or what are your anxieties and fears about ketamine? Special anesthetists that you've been using ketamine quite a long time, and now suddenly it becomes a drug for psychiatrists. And I see you mentioned that the Society of Psychiatrists of South Africa has actually given the go-ahead to use ketamine. And we've got psychiatrists here, so I'm sure we want to hear from colleagues from psychiatry who are logged in. Any comments from your side, colleagues, before I mention names?
I think Tokozile says, the psychiatric mental health nurses, I imagine that would be part of the mix.
Yes.
So we'll be reviewing the membership and the processes. So hopefully we'll come out early.
So it's open to nurses also?
Well, I think we've got to explore. I don't think it should be a problem, but I think we're still busy discussing the question of, the membership. It's been, if you look on the web, it's not available, and there's certain things that need to be fixed up. So I'm relatively new to these societies. So I'm trying to get myself familiar with what's been going on.
So the non-availability of ketamine in the public sector, is it because maybe in the primary healthcare setting, it is not easy? I mean, it's not being used ordinarily. It shouldn't be there in the primary healthcare setting. So you may find it
understandable.
Also,
you're right. It's not a routine drug that should be available in a community health center or a clinic, although it could be used for various reasons, not mental health or chronic pain. But it needs a hospital setting to be able to use it as an anesthetic. And community health centers, as they stand, don't have that capacity of being able to manage a patient intubated. So for the public service, when I tried to get it, I actually reached out to both Barra and Becky from Soweto, using the pharmacists in the area, and they battled to get it. And we've in fact got 5 vials of it, 5 ampules, which is a battle. And I would told her, can I get 60 to try it on, about 10 patients? And now I've got 10, and I've got to think, gosh, how do I divvy it up and try it out on patients? It's that kind of difficulty, and it's been about 2 months that trying. So it's really not easy. I imagine in these psychiatric units at Barra, they should be looking at it, but I think, as I say, there's a sort of resistance to taking it on in that circle. Not everybody is convinced. So I hope that, these naysayers, I can convince, one of them being my brother, Professor.
I was thinking about that you must give him some kind of a debate at home. Where you
Tell me. He raised lots of very hard questions.
Yeah, but tell me.
He wants to see this video.
Yeah, well, in a community healthcare center or primary healthcare center or setting, you say it's an infusion drug, but then how do you manage it? Because I think these patients go home. So you mentioned that sometimes you take it for a number of days, but just maybe the dosaging, how does it work? How do you prescribe it?
In terms of the way in which the drug is given, it's essentially needs careful monitoring. I think that's one of the big challenges because of the hypertensive crisis that might emerge depending on the patient you bring into that. So clearly you need to make sure that the patient is not high risk from a side effect profile. It's the hypertension that you're worried about. Also cardiac arrhythmias that you need to be a little concerned about. But remember that a patient can arrest, and so you need to be able to intubate the patient. So you need the monitoring services and the ability to manage, acute care or advanced cardiac life support. So you need to be able to manage the patient, and in that kind of setting. But the actual infusion for this purpose is about 40 minutes. It's an IV infusion, a simple drip, and then the patient is asked to cover the eyes because it's a very disturbing experience. They need to cover the eyes, some soft music, and that essentially allows them to go into this dissociative state. Many times the problem is actually the anxiety, and allowing and preparing them for the process. It stops after 40 minutes. They can, in fact, get up and get out of that place within the hour, depending on how they respond to anesthetics. Within 2 hours post-infusion, they are fine. The drug actually leaves their system within 4 hours. Anybody who comes to a clinic needs to be coming with somebody and not allowed to drive out of there, knowing that they're not quite... they're still in a sedated state or sedated state. And I think that's really the key concerns. Preparing the patient for the infusion, I think, is not just the physical infusion. I think that's why the work with a psychiatrist, psychologist is quite important. You need to actually understand, get the patient to understand, firstly, to be reviewed that they indeed are warranting such treatment as the part of the array of interventions possible, drug and otherwise. But then they need to be prepared for the experience in terms of their stage of change, you might say. Are they clearly wanting to make that step, and have they got clear goals for that process? Because yes, it will create a state of neuroplasticity. But if you don't have any clear formulated thinking, reviewing your history, thinking of, having questions about what you have accumulated over the years that is behind your problem, and then sitting with that, and then preparing an intention out of an informed thinking of that you then go through this procedure and thereafter be able to integrate it as well. Integration, or in fact, psychotherapy is considered a useful adjunct. I think you might have seen it in some of the literature that I put out there, that psychotherapy is seen as very important adjunct to it. You've got all sorts of variations in that. But it is not as easy. There's some clinics in the US where they do psychotherapy within the state of dissociation, but it isn't an easy thing to do because a person actually needs to let go of reality. They can't really communicate during that time. But it is useful the next day or a few hours once they are more lucid that they can actually think a little bit and review the process, the impact on their feeling and thinking. So I think that's really the way in which it would be experienced by a patient and how you could manage it in primary care. So you need that kind of thing, whether in the public or private. Of course, getting a monitor in the public service can be challenging to use them aside. So I think just in the clinic, we have to go and beg a little bit to say, listen, can we use it? Hospitals should be able to do this if they have the equipment available.
Yeah, definitely. So that clearly states that with GP practice, it's unlikely to be an ideal setup to use it, unless if the GP practice is a setup where they are able to intubate if the way of access to that.
Yeah, remember that a general practitioner may have difficulty setting this up. And I think that's one of the things that within the SOCAPSA at the moment, in the guideline by the SASOP, they in fact limited it to GPs with anesthetic experience. That's a diploma or an anesthetist. In fact, the SOCAPSA is led by an emergency physician who's skilled in using anesthetics in the sort of emergency setting. Family physicians have that skill and qualifications. So it will probably be limited by that kind of training, considering that it is not a routine drug that should be used in primary care. So as a family physician, yes, I work in clinics. It would be something that I could manage. But I don't think it's something that any doctor can just do. But I think that's one of the debates going forward is what is the sort of ways in which practitioners may be able to go. I think there's a lot of very dubious practice going on in the US and a concern about safety and ethics about overuse and no controls, etc., because it is a drug that people can develop a psychological addiction to and then be abused, for that purpose. So I think it's a concern.
Yeah, no, thanks. I think Prof. Radamine wants to ask a question or comment. If you are able to unmute yourself now, Prof.
Thank you.
Yes, thank you, Dr. Bila. Prof. Moosa and I have worked together for many years, but I'm a little concerned about ketamine. I just want to raise a few things. I'm mindful of the time.
Okay.
What is clear? Can you hear me?
Yeah, we can hear you. Go ahead.
Yeah. What is clear is that for treatment-resistant depression, it seems to work very well. But the data that has come from the USA, UK, and Canada seems to be questioning how long that wellness will last. It seems as though the relapse rate is very high. So maybe Prof. Moosa will comment on that. Secondly, there's been a concern, I've chaired preliminary committees of inquiry at the HPCSA. Particularly the anesthetists were referred had abused, ketamine. They were addicted to it. Some of them are still in the system. Some have been helped and so on. How do we control for that? Because it's still a good anesthetic agent and so on. Thirdly, Prof. Moosa will agree with me that in recent times, there's been a plethora of approaches that around which there was a hype. For instance, the various types of deep brain stimulation. Same as when ECT came in, it was a major event and then people lost interest. When mindfulness came in, everybody wanted to study different types of mindfulness. Now, ketamine is here and it seems to be promising. How do we help colleagues to select what is best? Because some of us are really steeped in psychotherapy. I personally don't believe that drugs and these approaches on their own without psychotherapy can assist the patient long-term. Is it true that the relapse rate is high? That is, the good effect is short-lived and so on? That's one comment. Secondly, how do we help colleagues to choose what is best currently? Thank you very much. And I want to thank you for the brilliant presentation, because it gives us more insight into what ketamine is. Thank you.
Can I add a third one or the fourth one? I'm not sure if you may comment, Prof. Daman, because I see Prof. Moosa has indicated that the Society of Psychiatry is actually created a go-ahead. Maybe you may comment whether there's consensus within the society about the use of ketamine or not.
Let me just point out that I received communication from the society. Initially, there was consensus, but then there was caution on that consensus. Maybe some colleagues who are on the platform might want to comment, because all I think the society was saying is it's good, but let us be cautious. So maybe Prof. Moosa will comment on that too.
Okay, Shabir.
Yes, thank you, Prof. Othmani. And I think, I don't disagree with you. I think I've presented the data, and I've been very careful to say what I want to present and what I would be doing, needs to be led by the evidence. And I started out by saying that at the outset, I have personal experience, but my curiosity was, does the evidence support that? Is it just a fad, as you point out? And I think that, yes, the studies suggest that it is, at best lasts for a month. And remember that you're getting 2 weeks infusions and it lasts for a month. The problem is that there have not been enough studies to look at what is common practice and with a lot of cases that are not strong enough to suggest that, that it is strong evidence, but it's not been studied properly. So I think that, to me, the practice in the, amongst many of these practitioners is that they give the 2 weeks of infusion, which is 40 minutes either twice a week or 3 times a week, 6 infusions over 2 or 3 weeks. And that's the common practice globally. Then from there, usually there's a top up and after a month. And for me, the question is, well, if that, and the experience is that top up as a monthly doesn't always continue. It, in fact, sometimes after a year becomes less and less. Now, all that is just case reports. It's not strongly evidence-based. So I agree with you. The long-term value is not clear enough, but that doesn't mean it's useless. It means that we need to actually examine it better. And that's why I think the promise is more important than the evidence right now. It says, yes, use it in the suicidal patient, the treatment-resistant depression, and then we need to see, well, is it just a month long? If not, whether there's value.
Can give me 50 and change something I need.
I think it is important to understand that it is not a fix-up. There's something like people saying it's a cure-all, the mental health cure-all. I think that's nonsense. It is really just one of the arsenal available in the mental health space. And I think that we should not think of this as you might say, or become very biomedical in saying that, an intervention is helpful. I agree completely. This is just simply something that helps you reset chemistry in your brain. But without the psychotherapy, without the support to the patient, without helping them with drugs that will manage it, and the kind of psychotherapy that helps them to manage their condition and social support, you're really not wasting your time to just take a ketamine infusion. So I agree completely on that. I think we just need to study it more. I think in terms of abuse, yes, I think that is a problem. And I think that's the reason SOCAPS is saying, let's be very careful about how we go about this and manage the thing. We are trying to speak to medical aids to see if they will support this. Discovery is interested in doing it. They see its value. I think we need to just look at building the evidence base, but also guarding against its abuse, like you say. So I think that's a valid comment. I think when you say interest, the faddishness of it, of course, at the end of the day, we need more data to support it. I I mean, the other so-called fad, but it's collecting a great deal of evidence around it, is the DBT, dialectic behavior therapy, and I'm sure you're familiar with it and know that it's gathering steam. Again, it needs to not just be an interest. If the evidence supports it stronger and stronger, it needs to become part of our arsenal. And I think that we need to just deal with that problem by evidence. And that's why my presentation has been completely based on, well, what's the evidence telling us, and looking at the quality of evidence that's there in the public domain. Thanks, Dr. Prof.
I'm not sure if you answered the question about patient selection. How do you help doctors to select patients?
Well, essentially, it's at the end of the day, the selection at the moment is treatment-resistant depressants, and depending on where you are, in most common consensus is after 2 antidepressants that you failed with, that you can consider ketamine, and that's an adequate dose and adequate duration on it, knowing that these things don't change immediately. So I'd say 2 months, change of drug every 2 months. I think you might consider it, but remember that it's part of a whole mix. So you need to take all of that into account. So that's what I would recommend in terms of patient selection. I think the suicidal patient, you get patients who are potential, whether they get admitted, but the effect on a suicidal patient is quite dramatic. And I think that is worthwhile considering. Sometimes one ought to admit them, but I think it's a tool that's available in these settings and could have dramatic results and reduce waiting times in hospitals or bed occupancies.
No, thanks a lot. I know that we must be mindful of time. We debate about time, that you've got time constraints. But before I close, I wanted to check this. We had a view from the psychiatrist, this nurse who spoke. I saw 1 or 2 anesthetists. Any comments from, maybe pick Dr. Mtonga from your side, just an anesthetist, what Prof. Rata might have mentioned, if you're still at Dr. Mtonga? Or is it gone? Okay, no, thank you very much. I'm sure but it has been an interesting discussion, and I think quite a different angle. I didn't see it coming. That is going to be one track coming and talking about a particular, but I think it's a talk of interest, and I think the research, you've provided sufficient data that you can look at. And also the fact that you said we can access your website. These webinars are recorded on YouTube, so colleagues can go to YouTube and check it. But I think the website is the best place to go to get information about the work that you're doing and latest research.
If I may mention that on the website, there are many more studies and many more articles available, all cross-linked, so you can go to the original source, the actual article, if it's publicly available as a PDF. Otherwise, if you can access the library, you can access them all. So I think there's much more there. So please have a look. And I'd love the interaction. So if you have other studies that challenge it, please feel free to send it to me.
Okay, thanks. I think what we'll do, we'll just post the website address once more when we send to the reviews or surveys to the colleagues who logged in. So just also send the website if colleagues to go and access it once.
And the presentation has been sent to your organizer, so it's available. I imagine you'll send it around to everybody.
So we can share the presentation with those who. No, thank you very much for that. And I just want to say thank you very much for the time, for giving us your time and all this assistance you've given me in the last few weeks when I was looking for other speakers. And quite nice presentation, food for thought. Somebody put it there, that it's a quite good presentation. And as you said, we've got access to more information that we can do that. And also to thank all the colleagues who have joined in this evening. Quite a number of them have been logging in since 2020, from the time of the lockdown, and it's been going well. And their presence here means that we're doing a good job, and people like you make us want to continue with this, because we want to be a thought leader in terms of continuous medical education and latest research, as you've done so tonight. So just want to
If
thank
I
you.
may, if I may, Dr. Bila, I'd love to, if you got time to present on DBT, because I think DBT is really useful and people ought to
No,
understand.
we're not deep in thrombosis when you say DBT.
Dialectical behavior therapy, cognitive behavior therapy, because I think these can be learned skills and they can be very useful. But the other one I'd love to talk about is the NHI. I think we're implementing in Soweto, and I think it'd be really great to talk about what's going on there.
Now we'll have a conversation about it. We'll put some dates together for the future. Yeah, so we've got still a few more months to go before the end of the year.
Thank you very much, colleagues. Thank you all.
Yeah, thanks a lot, colleagues, and thanks a lot to Kamo from marketing and the team that works with me and in putting together this webinars. And we look forward to seeing you again. Unfortunately, next week it's just before the Easter weekend to the Thursday, so we won't be having the webinar. So we'll be reconnecting again, I think the 9th of April after the Easter weekend, colleagues. So we trust that you'll have a good evening and have a restful weekend too. Thank you very much.
Bye-bye, everyone. Bye-bye.
Thanks a lot.